All right, so we're starting back up. So we've covered some of the basic stuff, and the goal is we're just going to move from topic to topic and hopefully try and integrate these things until we can ultimately talk about real things that matter. And we're starting to get there. And so I'm pretty excited to give these next few lectures because they're cool, in my opinion. And so we're going to be talking about inflammation and the immune system and how that relates to psychiatry. And, oh yeah, I caveat all of my lectures. I haven't done microbiome in a really, really, really long time, and my understanding of all of these pathways is not quite expert, and I've just sort of gone over them. So I may make some mistakes, but the idea is we're going to get the general gist of these things to sort of see how it all ties up. And it's also a continuation of the last lecture when we were talking about the autonomic nervous system and cortisol. So it's sort of going to be using a lot of those principles. So I'm going to recap some of those as we need to as we're going on, but not focus on it too much. So I don't know if anybody read the handouts, but I was talking about, what does this look like? What does inflammation look like? And try and get, again, a nuts and bolts sense of this so we can make sense of it. So the classic, you whack your finger with a hammer. And, this is the cartoon. We all know this. It turns red. And, I think this was a great illustration. It really sort of covered what, we know about inflammation. And in med school, they make you learn a lot of Latin. But, it's the redness, it's the swelling, it's the pain, it's the loss of function, all of those things. And, we're going to hopefully be able to understand how those happen mechanistically on a molecular level. And I think that's pretty easy to do. Making the site connection is a little bit trickier. And so again, it's the rumor, tumor, dolor, color, all those sorts of things. All right. So we're going to talk a few different ways about how you can get this whole immune party started. And, the first one that we talked about was physical trauma. And so, I don't even know what that thing is, going in and breaking up skin cells. But you can imagine you've got cells, and they've got guts in them, in the cytoplasm. That's generally not exposed. So when you do, physically pop some of these cells, for lack of a better word, they dump their guts out. And the stuff that they have in them are things like histamines and cytokines. And additionally, they have the phospholipid bilayer that we had talked about. And that phospholipid bilayer is often the starting point for the eicosanoids. And we're going to talk a lot more about those later. So I'm going to be using a lot of words that sound really big and ridiculous, and I'm going to try and make a little bit of sense of them just to give you a general understanding of what we mean when we say those things. So stop me at any point if I'm sort of just speaking nonsense and it's not clicking at all. So that's the first step. So that's one way of getting in and getting the histamines and the cytokines and the eicosanoids going, by a cell busting its guts and exposing it to the environment. And we'll talk about this later. So the second way that we can get into the system is through a pathogen entering. And again, we want to get to the same sort of end path so we can move forward. Hey. So here you can see there's a wound and pathogens have gotten in. So, these are all numbered as if it happens in a nice cascade. It's a little bit sloppier than that. It's all sort of happening at the same time. But generally, these pathogens are going to come in. And this is a macrophage here. And sometimes there's resident macrophages just in the tissue. And what this macrophage does is it's got something called a pathogen recognition receptor. And that's really just a generic term for something that can recognize a pathogen. And the main goal is to recognize pathogens and not recognize not pathogens. So it's the whole idea of it wants to be able to identify us versus them. That's the main goal of a first pass of the innate immune system. And I'm, again, using terms like innate immune system as compared to the adaptive immune system, and we'll talk about that as we go on. And so these pathogens have what they call pathogen-associated molecular proteins, which are generally just things that are exposed that they have that we don't have. And those can be various things, and the macrophages have the receptors to lock onto those things that they have and we don't have. And so once that happens, it starts this same cascade. So the macrophages, again, release cytokines and release histamine. And so now we're at the point where we can understand how physical trauma or a pathogen can lead to histamine or cytokine release. And so what that's going to do is the histamines are going to go into the endothelial cell, and they can make it vasodilate. And so you can imagine if you've got vasodilation at that point, you've got swelling, and you've got stasis. So the cells are going to begin to slow down there, and you're going to get that swelling that we see. There's going to be an increased blood flow, and that's going to be sort of the redness that you can see. The cytokines are going to come out, and they can do a lot of different things, and there's a lot of different cytokines. And when I say cytokines, all a cytokine is something that can do something in the immune system. So it's an immunomodulatory agent. It's sort of like a leukocyte is a white blood cell, and there's lots of different leukocytes. A cytokine is an immune thingamajig, and there's lots of different cytokines, like the interleukins, the leukotrienes, all those sorts of things. And I want to try and sort of cover these broad concepts so we can work with the terms to some extent. So the macrophages release cytokines like IL-1, IL-6, and CXCL8, I guess. And so those are going to do a lot of different things. So we talk about the exudative phase versus the cellular phase. The exudative phase is when the mast cell releases the histamine, gets into endothelial cells, they open up, and plasma can then leak in here. In the plasma is all of those things like the complement cascade, kinins like bradykinins, which can cause pain, fibrinolysis type things, clotting stuff, so that it can fix the wound or whatever. And then what can happen is this whole cellular phase, and you can see that neutrophil coming in. And so what happens is because of the endothelial effects, you're changing the flow pattern, and this is just a matter of the properties of flow. When you change the diameter of a pipe, you change the flow. And what that allows the neutrophils to do is to more easily attach to the endothelial walls. And these cytokines go in there and they put these things called selectins on the endothelial cell walls, which can grab the neutrophils. And again, this is way more detailed than you all need to know. I just want to give you sort of a nuts and bolts sense of how this works. So the neutrophils are more likely to be at this endothelial cell wall. The selectins are there to grab them. The stasis is there, so the flow has decreased. And then they're going to get pulled into the tissue. And then, as I had said before, CXCL8 is a chemogradient cytokine. And so when these things get into here, they follow the gradient up towards where the area of inflammation is, and then the neutrophils can then release their own cascade of cytokines, like IL-1, IL-8, interferon, all those fancy eicosanoids, TNF, tumor necrosis factor. So I'm throwing out a lot of words, and I'm hoping sort of by repetition we're going to get to understand them. So that's the general basis, and I covered most of sort of the rubor, tumor, calor, all that sort of stuff, the heat from the increased blood flow and all that sort of stuff. And so that's generally the innate immune system. The adaptive immune system, what would happen is once these things get engulfed, they can then get back into the blood system, or into the lymph system rather, get into the lymph, and then present these things to cells in the adaptive immune system. So present them to B cells and T cells so that we can then start our adaptive immune system, which I'm not going to talk a lot about. And most of the data doesn't talk about either, but my guess is that it matters too. Most of the focus on psychiatry is in chronic activation of the innate immune system, all this macrophage interleukin business, and doesn't focus on sort of the more adaptive immune system mediated things like antibodies and these targeted like Th2 cells and all that sort of stuff. So again, we can see here it's a lot more complicated. There's a ton of stuff going on. But just again, we sort of understand this at this point. A pathogen can come in, which can do different stuff like activating macrophages or breaking down cells to get these eicosanoids here, which are in the cell walls. Or similarly, we know that we can get into this sort of histamine side of things from just busting open a cell, and we can get into the lipid side from the cell phospholipid bilayer. And then the histamine can introduce the exudative phase, and we can get the cytokines here, which we know are going to activate the immune cascade and tell it in which direction to go. And ultimately, we can have the invasion of neutrophils and then taking it into the lymph to begin the adaptive immune system. So this is just a very brief overview of what happens in our body when we get a cut and we need to heal it, when we get viruses breaking through our skin, getting through our mucosa, and we don't want them to I guess, mess up our bodies. So just a brief overview of what's going on. The innate immune system, again, is what we're going to focus on. It's based on the cellular level. You're born with it. You don't need any exposure for it to know what to do. It doesn't really get better as you get exposures. And again, it's antibody independent, whereas the adaptive immune system, to the contrary, it's not a lot of animals have it, or rather not a lot of insects and other sorts of things have it. I'm guessing most mammals have it. I don't know how sophisticated it is all the way down. But it's sort of a more new, fancy evolutionary adaptation that we have to fight bacteria. And so again, it requires activation so it can learn how to make these things. And it's antibody dependent. And you know, the analogy that I relayed, which is one from, I think it's actually Charles Raison's analogy, and we're going to talk a little bit about his work, is the idea of the innate immune system is sort of like the redneck with the shotgun. He's indiscriminate. He doesn't like your people from around those parts. You know, he just knows that you don't look like him, and so he blasts with his shotgun. You know, whoever else is by, so be it. You know, we got the guy. Versus the adaptive immune system, which sort of, you know, it's got all its intel, it's got a debriefing, it's got its mission. It goes in there and it takes out the invader without a lot of collateral damage. All right.
Now, interferon is part of the adaptive.
So it gets a little bit messy. Generally, interferon is part of the innate immune system. So, but they use each other a good bit. And so I don't know the specifics of it, but interferon is generally coming from neutrophils, not coming from B or T cells. Although it can get very, very messy in the way that it can sort of loop back and interact with each other. When I think of the adaptive immune system, it's generally epitope specific. That's what sort of is going to signal it. It's either an antibody binding to it or something recognizing that antibody and then eating it, sort of thing. And maybe interferon is involved in finding those things. I don't know the specifics of the pathway. My guess is the answer is yes, but it's generally thought to be in the innate side of things. And then the other question is, you know, how does this stop? So we sort of know how it starts. And so this is sort of good news. Most of these things have short half-lives. The interleukins, the leukotrienes, if nothing is driving them, if nothing is creating more of them, they just go away because they have short half-lives. They get processed by the liver or by the kidneys. I don't really know how. And like most things that are important, there's things that drive it forward, and there are things that sort of regulate it back. And so it has its own feedback mechanism. So usually the things that cause the inflammation can then feed back to decrease the inflammation. We see this all throughout the body, allostatic mechanisms of regulation. That's a theme that's going to come up over and over and over. Our body has a lot of different things that are really great to happen at the right time for the right amount of time, but can be really, really bad if it happens at the wrong time or for the wrong amounts of time. And that's something that we're going to talk about a lot as we talk about lots of different neural mechanisms. It's great to have a little bit of anxiety at the right time, but having it at the wrong time or having too much of it is not a good thing. And that's sort of, a meta-phenomena of what we're sort of looking at here. And again, lots of these things can decrease the inflammation. There's possible therapeutic targets in here. We can talk a little bit more about that at the end, but you can imagine if interleukin 1 or interleukin 6 is going to increase inflammation, if you can sort of put a receptor antagonist in there or something that binds up the interleukins, potentially you can decrease the inflammation. Also notice the omega-3s are in there. I'm going to talk a little bit about them to give us more of an understanding. They're also part of the eicosanoid pathway. And then again, cortisol in the autonomic system. This is sort of where it comes back again. And we all think that cortisol is an immune suppressant, and it generally is, and rather it is, but the things that come with it often trigger the immune system, and that's really where we're getting at. And so it's going to be very, very complicated. A lot of it is going to depend on what kind of stressor, how long the stressor lasts, what is our underlying sort of genetics, and all those sorts of other things. But we'll cover that a little bit more. But again, the point of this is that it's about balance, and there's lots of ways that it can be balanced one way or another. And so because of that, there's lots of ways for things to go right or go wrong. All right. So this formally starts the talk. So this is going to be where we're beginning to make the connection between inflammation and psychiatry. And so I guess 30 years ago or something like that, the field of psychoneuroimmunology was born. I would have put psychoendoneuroimmunology, but I ran out of space for pictures. So does anybody know where that's from? Psycho. Okay, good. I took me. Yeah, that's right. I think it's a great, great picture. So psychoneuroimmunology should have been a field that we recognized 1,000 years ago, right? it pretty much started when people realized that, hey, look, our brains and what happens in our environment can influence our body, which to me is sort of like very common sense. And our grandmas told us, you're going to worry yourself sick, and there's all these things in the layman's crowd. I mean, we knew this, right? But it took a scientist doing an experiment before we believed it. And the initial experiment that they did was awesome, actually. So they had rats, and I don't know why even they did this exactly, but they fed rats saccharin-flavored water that was laced with cytoxan, which is a nasty, nasty chemical. I think it's cyclophosphamide, which is like a mustard gas type agent. And it would cause some taste aversion, it would cause some GI symptoms, but it also was an immune suppressant. And so what they did is what they found was after they they fed them this saccharin-laced cytoxan water for a period of time, days to weeks. Then they took the cytoxan out, and they found that just by feeding them the saccharin-laced water, these rats were dying of overwhelming immune infections, bacterial infections. And then they sort of did more experiments and found that, hey, look, these rats look immunosuppressed when they're just drinking the water. So their brain was able to make a conditioning, like via Pavlov-type conditioning of saccharin immunosuppressant, and make that conditioned stimulus into an unconditioned stimulus sort of thing. And I think that has a lot of actual therapeutic benefit that I've never seen people try to use. And you can imagine, give somebody morphine in their Kool-Aid when they've got a chronic pain condition, and maybe potentially you can ramp up their natural opiates. But we can get into more brainstorming later. But the idea that we can do that really got me thinking, and I've never seen anybody try and run an experiment like that or anything. All right, and so why might this be? Why might it be that what happens in our brain and in our environment can lead to a change in our immune system? And to do that, I've got to spout a little evolutionary type stuff. And I actually believe this more than not because it really gets at nuts and bolts of what evolution is, and that's pretty much, not dying and reproducing. And so when you go back and ask the anthropologists, what happened back in the days when we were, still real men and women in the cave sort of sense, how did we live, how did we die, and that sort of thing. Well, most people either die from being eaten or of an infection. And that's what we find from, I guess, however these anthropologists know what they know from bones or whatever. And so if you think about it, if what is killing most of you is infection, you really need to know how to fight that infection. And so the next question they asked is, what is going to cause an infection back in the day? And usually a few things. You're either trying to eat something, you're getting eaten, or you're trying to reproduce. Those are very risky things where the chance of tissue wounding or somebody putting a paw in your face are pretty high. And if the chance of infection is high, you probably want to prime that immune system. You want to get it ready. In the event that something happens, you've already got a bit of a head start on it. And that's sort of the evolutionary theory behind it. I don't know how perfect it is, but it's better than most evolutionary stuff we talk about, in my opinion, in psychiatry. So that's great. That's super helpful for a caveman because, like I said, they don't have the luxury of dying of cancer when they're 82. They don't have the luxury of dying of a heart attack when they're 74. And the idea is that was likely a very, very adaptive response to them. If you can save yourself from infection a few times, you've lived longer, you've reproduced more, they're not going to live long enough to suffer the consequences of this chronic activation of the system. And this is, again, getting back to the same sort of thing. Right time for the right amount. Cavemen weren't stressed that much. They didn't have mortgages. They didn't have cars. They didn't have ties. They didn't have 9-to-5s. It didn't really work that way. And in fact, when you look at the hunter-gatherers, their lives were way sweeter than ours. Minus computer games. They didn't have that. But so the idea is that what is a very, very adaptive process may have some maladaptiveness in today's society in the way that we live, and we'll talk about that a little bit more. But I can't really say this enough. It's about, the right amount of whatever's happening at the right times, and that's going to be something that's going to come up over and over in each sort of bucket that we go in of understanding, whether it be genetics or epigenetics or the neuron or inflammation or stress or the autonomic system or functional pathways or even things like anxiety or depression. not necessarily depression, but sadness and that sort of thing. All right, so here's a really fancy picture, so it must be true. So what we can see here, this is coming from a paper by, I guess, Andrew Miller, Vladimir Maletic, and Charles Raison. They're down in Emory. They're doing a lot of this neurobiology stuff, and it's very good stuff. I'm going to poke a lot of fun at them, but I actually respect their work a whole bunch. And so it starts with stress, right? We have this stress. I've never seen anybody write anything good about what stress is. And so I'm going to talk a lot about that in the next 2 lectures. What is stress? Early adversity, interpersonal conflict. It's so vague and nondescript and non-personal. That's not what stress is. When I go home and complain to my friends, I'm like, so much interpersonal conflict today. No. So it's a personalized thing. Whatever stress is individualized. It's largely learned from, some hardwiring. But we'll talk more about that later. But I think it's important to challenge just this idea of stress because it's obviously a vague concept. It's very different from person to person. And being able to understand that, I think, helps us a lot as people who want to help people.
And it may not be that you want the absolute lowest level. There's some optimal level, including novelty in your life. And so we don't want to have it at the very bottom.
That's right. And think about a roller coaster, right? Think about anything that you enjoy. Generally has an aspect of the stress response. Stress in the right context can be very helpful. Think about going to the gym, right? So if you go to the gym and you're lifting those weights, it's great. Imagine if somebody made you do that. It would be torture. And so again, Dr. Hobbs is very much right. It's not about avoiding stress. It's what they actually in the field term eustress, which is sort of positive stress versus distress. And we'll talk about that a little bit more. But that's absolutely, the goal of life is not to avoid stress and be whatever a person who avoids stress is. It's about managing the stress in your life, trying to make as much of it positive, and we'll get more to that later. But again, this is harking back to last lecture on the stress system. It comes in, it can get in the HP axis. We saw this CRH business. This shows CRH going down into the sympathetic chain. That's not really what happens. As we said before, it's getting into the amygdala, which can get down into the brainstem, the medulla, which can then send its pathways down the sympathetic chain and ultimately out. This is what they talk about mainly in this paper. There's likely other ways to get into the immune system, but it's thought to be sort of an epinephrine beta-2 receptor pathway where it can come down the sympathetic chains, get into immune cells, whether it be macrophages or otherwise, and upregulate the immunity. And they're going to talk a lot about NFKB, which is nuclear factor. I can't even remember this. Nuclear factor kappa light chain associated of activated B cells or something like that. But you remember, there's and this is a great point of why I think that, the adaptive immune system is also involved. Because when you think about kappa light chains of beta cells, now we're sort of in the realm of the adaptive immune system. I didn't go over this stuff, but there's the kappa chains, the light chains, and I don't really remember it, but there's 2 in 1 or something like that. That's not very helpful at all, but that's my understanding of it. Yeah, it's these sorts of things. So it's whatever makes up some stuff that does some stuff.
I've got to write that down.
Yeah, that's on the test. So again, you can see how it can come down in here and upregulate NFKB per this diagram. And then it shows a parasympathetic system coming in and inhibiting it. And, some of these things that we talked about earlier. And similarly, getting into the cortisol cascade and inhibiting it. And you can already see here, we sort of have an allostasis going on, or a homeostasis, where there's pushing and pulling. And depending on the various things, you can get various types of responses. And we're going to talk about this pathway more, the parasympathetic pathway, and how that might be interesting to us. And so, again, another fancy diagram. This is focusing on the brain. So you can imagine this is the blood feeding the brain. This is inside the brain, whereas some of this, was on the periphery out here. Oh, yeah, sorry. Once you get to NFKB, so NFKB is a transcription factor, which is a protein, which is made from... Somebody, please. What are proteins made from? Amino acids, which come from... DNA, which is made in genes. So everything that's a protein is made from a gene, either directly or indirectly. It may be a protein that's made and then another enzyme which is made by a gene makes it. But again, you can already start to see we're in the realm of genetics. We're never leaving any of these realms. They're all there, and we just pull them in as we need them to understand some of these contexts. Again, CRH and CRH receptors. We're talking about neurons. We're talking about genes. We're talking about ions. We're talking about all this stuff as we're looking at the level above it. And so this can be one of the sort of cardinal transcription factors that gets the inflammatory cascade going. And so this is how we can get into the same cascade that we saw from whacking your thumb or from a pathogen coming in, because it's releasing the same things, the IL-1, the IL-6, it's bonding to the mast cells, which can release histamine, it's doing all that sort of business. And then we see it gets up here. And so an interesting sort of fact is that these things can't cross the blood-brain barrier. They're proteins. Almost all of them are proteins. Proteins are big on the order that there's no way they're getting across the very tight blood-brain barrier. So we know that they can have influence in here. We don't exactly know how. And they list, possible ways. And it sort of makes sense. It can either be actively transported across. It can send a signal to the perivascular macrophages that are sort of right there when they've got sort of detectors in there that can detect stuff. It can get in peripherally, which is probably highly likely, just meaning that you give it in the periphery and there's some nerve out here that gets up into our brain that tells our brain something. So we don't really know, but it doesn't much matter for this. I mean, it matters if you're going to do some rational therapeutic stuff. But it does, because you give a medicine peripherally or you stress somebody, and we'll talk about that later, and it works this way. So here you can see the peripheral inflammatory response coming in. And there's a lot of stuff here. And this is sort of the world that we're used to of glutamate and tryptophan and all that sort of stuff. So I'm going to talk through it a little bit, and then I'm going to talk bad about it a little bit. And so what they're saying here is that this peripheral inflammatory response can come in, and that cytokines come in, and what they do is they work through various enzymatic pathways in the brain to upregulate this thing called indole did I write it down here? Indole 2,3, I didn't write it down. It's like indole 2,3 dioxygenase or something like that. But all we need to know is that what it is something that can shunt tryptophan into something else. And so tryptophan, if you all remember from before, usually goes to 5-hydroxytryptamine through, anybody remember? Tryptophan hydroxylase, which is the gene and all these things. Anyways, so what you're doing is you're shunting from tryptophan to something else as opposed to serotonin. And that's one way where, if we've got decreased serotonin, we've proved it. It obviously causes depression. So what you can see is that this increases indole 2,3 dioxygenase or IDO or whatever, which can then do a lot of other things. So in the microglia, it can get converted through something called kynurenine to quinolinic acid, which these things are going to be things that in the next few years we'll probably hear some about. They'll try and make some drug that can target them and sell them, and it'll probably work for some people. So it's interesting. I'm only mentioning them because I think that they're important enough to sort of know. And then you can sort of see lots of other stuff happen. So these things can then feed on to the astrocytes. Oh yeah, let me talk about what's going on this slide before I start there. This is a microglia. So this is glia, this is glia, this is glia, this is a neuron. So this is a microglia. And so microglia are pretty much the immune cells of the brain. So they detect if there's a pathogen in the brain and they do stuff with it. The astrocytes are the most numerous. They sort of provide the structure, they provide the milieu, the nourishment, and all that sort of thing to keep the neurons going. The oligodendrocytes are the equivalent to the Schwann cells in the periphery, and they're doing this myelination business. All right, so that being said, all these things can release stuff that interacts with everything else. And what we can see is that these cytokines and chemokines and all that can get into the astrocyte. The quinolinic acid can affect the astrocyte, and it can do a few things. It can cause an increase of glutamate release and a decrease in glutamate reuptake. And you can imagine that that has the potential for setting you up for excitotoxic injury. It can decrease BDNF and excitotoxicity here, right? And so we're talking about like all these things that are in a cascade. So we've got lots of bad things happening and no good things happening. But that's not really the case because, glutamate in and of itself isn't a bad thing. And these don't have to necessarily be bad things. And you'll learn later when we talk about learning that increased glutamate, this might be part of the reason why we learn better when we're stressed, under certain types of stress. So again, it's getting to the idea of right time, right amount, good thing, wrong time, wrong amount, bad thing is probably what this is showing. But what they're getting at is that, hey, look, this has the possibility of affecting neurotransmitters, monoamines. It has the possibility of affecting cell death and myelination. And hey, look, these are the same patterns that we see in depression. QED, this equals depression. They don't say exactly that, but that's sort of the language that they're talking in. And I'm going to argue that it is, it's good data, it's good to know, and there's going to be an inflammatory part of it. And I think that those people certainly know that this isn't sort of a quintessential answer of what depression is. But oftentimes when we read it, we are led to think that, because that's sort of the way that we think. But just understand that this is associative type stuff. It has something to do with it, but it's not proving really anything here. All right. So this is less fancy, so it's less true, but it's by the same guys, and it's just saying the same thing. I sort of like this. Again, it shows the amygdala coming in, just generally able to get into both the stress pathway and cortisol, and the sympathetic pathway, and the neurotransmitters, and the cytokines, and then back up in the brain. Again, this is just showing a putative mechanism for how this whole psychoneuroimmunology business can sort of work. All right. So this is just a prompt for me to say how different stress signatures can cause different changes in the body. So stress is not stress is not stress. It's unique, and our brain has very cool ways of parsing that out. And if you actually chop up a brain and look at sort of what is going on in the amygdala, sort of going to, in the hippocampus, going to the pituitary, going to the adrenal, there's sort of neighborhoods. And so what comes from a signal from one place in the amygdala may go to a neighborhood that's 80% cortisol and 20% ultimately going to be an endorphin, whereas another one might be 80% cortisol, 10% growth hormone, and 10% thyrotropin or whatever. And so that's sort of the idea that each stress doesn't have to look the same. A physical stress can look different than different psychological stresses, and that's just our body's way of having multiple adaptations. So that tells us a few things. One, we can't expect to always see the same data when we're looking at these things, because it's so vague. How long the stressor is, the duration, the type of stressor, where we're looking, we're going to see very different data, because it's, again, getting into the hormonal business, which can have very different effects in very different areas. All right. All right, this is my soapbox slide. So I really, really like this slide for a few reasons. Because those previous slides that I showed don't equal depression, they don't really equal anything. They're just showing possibilities of things interacting with other things. And just because we have a putative mechanism, it doesn't explain anything. Like, fine, serotonin's up, serotonin's down, BDNF is up, BDNF is down. That's not very nuts and boltsy, right? I mean, sure, we understand that these things can modulate stuff, and this stuff might be important, but it doesn't ultimately mean a whole bunch to a clinician to have that information at this point. But I think that this slide does. So, I give a lot of respect to them for doing the data and presenting it the way that they do, thumbs up to Vlad and all that. But at the end of the day, I think they would agree, there's nothing quintessential to it. There's nothing causal to it. It's just sort of associative stuff. It's the beginnings of more research. It's the beginnings for possible rational therapy, but it's not really proving anything. So I'm going to talk about a couple of points. So the first one is this concept of reality first. All right, so reality comes first. And what I mean by that is you don't need to prove something for it to be true, and just because you've proved something, it doesn't make it true. So that is something that is very good news, because if you needed to prove something for it to be true, if you needed to understand something for it to be true, nothing that we did would work, right? Because we don't really understand it yet. So regardless of how we understand an SSRI to work, whether it be by increasing serotonin, whether it be by decreasing inflammation, it works how it works. Regardless of how we understand it, our body doesn't care what we write in a book. It's doing what it's doing. And so that's the idea of reality first. So even if you can't make up a putative mechanism for it, it doesn't matter if it's happening in front of you. If it's happening to your patient, they don't care about the mechanism. And I don't really care about the mechanism, because we don't have enough information to know that yet. And that sort of segues nicely into my next point, and that is, we live in a world where we are ruled by the tyranny of the double-blind, placebo-controlled trial. And it's really true. And everybody wants to know, what's the data for that? What's the evidence for that? What's nothing that we do? We are so far beyond evidence-based medicine. It's and to even talk about evidence-based medicine, there's a lot of politics behind it. There's a lot of money behind it. I'm not going to go into a lot of detail there. But sometimes it is not necessarily driven by the most caring, beneficent of people. And it's important to know the data. But more importantly, it's important to know the limitations of that data and what the evidence is. And people come to me frequently, sadly, and ask me sort of, what do I do in this case? What do I do? As if, like, I actually know something more than you. Like, the data is so minimal. The only thing that I can tell people is, just talk to the patient. Ask them what they want to do. Meet them where they are. I can't tell you anything about the evidence that you don't know. There's not a lot of it. I can tell you what we don't know pretty well. So, and this is going to get me back to this slide and why I like this slide a whole lot. We know that stress can affect us. We didn't need indole 2,3 dioxygenase to tell us that, right? Our grandmothers could tell us that. So what ultimately matters is what's really happening. And that's what I'm getting at. And so that leads me to this slide. Because it's simple. We've given these medicines, and we see what the effects are. And I don't know if you all have ever been on the consult service and have seen somebody who's been treated with interleukin or with interferon. But these people come in, and their wives will say, my husband is just not the same. He's yelling at me. He's cursing. He's depressed. So clearly, this medicine did something psychiatric. I don't care whether you can find a putative mechanism or not. It did it. And we know this from animal data. We know this from stressing people. You do a social stress test, the Trier social stress test on people. You check interleukin-1, you check interleukin-6, you check TNF, and they're elevated. They're not crazy elevated like they'd be in sepsis, but they're elevated, 60%, 100%, enough that you see that elevation day in, day out. You're stressed, your test, your patients, your 4 o'clock, you're this. That's going to increase your risk of cardiovascular disease. That's going to increase your risk of diabetes. That's going to lead you to obesity and all these other things that we see with stress. And that's the best evidence for me. It's great to know the neurobiology and stuff behind it. That's what this talk is about. But I don't want you all to think that we know the answers to these things. That's not what my goal is here. We're figuring stuff out. We want to try and think scientifically when it's helpful to think scientifically, not when we're missing the forest for the trees. So, again, I was talking to a cancer clinician who had just given someone in treatment with interleukin-2, and they were like, I'd rather die than get this treatment. And so these are not like modest effects. They can be huge effects. And this just goes through sort of the list of them and what they might be used for, and again, what some of the psychiatric side effects might be.
It's interesting on that list you have, there are no positive ones.
Not yet. Oh, but we'll get to the positive ones. This one is positive. So etanercept has been studied, and infliximab have been studied.
Maybe it's because if someone's a little more cheerful, they don't even notice it.
That's a good point. It's a good point.
They just think it gets better from his illness.
And until we do the double-blind, randomized controlled trial, we'll never know. The truth is there is a point. There is a place for them in clinical trials. But we don't need them to be able to make a statement, is what I'm getting at. All right. So a quick break from me yelling at y'all. So I would be willing to bet if we were to draw his blood, he'd probably have elevated levels of some of these things we've been talking about here. All right. So just going to give a brief overview of these things because you're going to hear about them a little bit, and I want you to have a little bit of an understanding of what they mean. You don't need to memorize specifics. Just get a sense of these are all sort of cytokines. They're classed a little bit differently. They do a little bit different things. They all sort of interact with each other. But we'll talk about some things that might be worth hearing at least once. All right, so we talked about the cytokines are just immunomodulating. So all these are cytokines. And when I'm reading from my slides, it can't be that important because I don't really know it. So the interleukins, again, we generally think of them as sort of getting the party started, the main signaling molecules. IL-6 is common in getting to the liver and commandeering it and getting it to stop making certain things and start making certain things. It's important in fever and those types of things. NFKB is a transcription factor. It's one of these sort of cardinal start points where you can get the whole system going that way. Again, we're in the world of genetics with a lot of these things because a lot of them are proteins, and so they're made by genes. And so you can see how you can ramp those up either by getting stressed too much, by either viewing the world as too stressful, or by having genes that respond to the same level of stress by just ramping up more of these than you necessarily maybe needed. So interferon we generally think of with viruses. Tumor necrosis factor is something that generally can cause cell death, maybe is important for helping not get cancer, and so we use that again as a cancer treatment sometimes. The eicosanoids are the one thing that is not a protein. They're generally fatty acids, and they're really actually very, very important. And that's that whole COX cascade, so anything that's a COX inhibitor sort of gets in there. We'll talk about that more later. But it's pretty important when we talk about the omega-3s and omega-6s, that's what we're talking about. They can be inflammatory or anti-inflammatory, but they're a large regulator of our body's inflammatory response. And so like the leukotrienes are in asthma, so like montelukast and stuff like that is a leukotriene antagonist. It helps with asthma. The prostaglandins are sort of endocrine type things, so they can have a variety of effects, but they act locally. The acute phase proteins are the sort of things that we will generally check when we're looking for an immune disease. So CRP, C-reactive protein, ESR, those sorts of things. They're just general non-specific markers of inflammation. They do stuff too, but I don't know anything in particular that they do. And one thing that I didn't mention before, so I mentioned interferon, but think about a time you've been consulted to the ER. Something terrible has happened. There's been domestic abuse in some house. A man was hitting his wife. The cops went there. He was yelling at them. They got in a fight. The cops had to hold him down and handcuff him, and they bring him in because he said he was going to kill himself. They order the basic labs. It comes back with a white count of 20, right? I mean, is this guy septic? Did, for some reason, the cops give him meningococcus or something? And when we see this, we've seen this over time, and we've said it. I mean, we've known it forever. This is an acute stress response. I mean, clearly we know that stress can have ways into the immune system. So this is the eicosanoid pathway. So up at the top, we've got diacylglycerol or phospholipid. You can think about that's what makes up our membranes. This is just this fatty, long carbon chain going on. Cortisol blocks that top step, phospholipase A2, which prevents that whole cascade from going into arachidonic acid. Arachidonic acid is an omega-6 fatty acid, all right? And so you hear a lot about omega-3s and omega-6s, and we're going to talk about what that means, and we're going to look at that in a little bit more detail. Arachidonic acid is an omega-6 fatty acid. And then it can get shunted either into sort of this prostaglandin pathway through COX-1 or 2, which is where generally our NSAIDs work, Celebrex, celecoxib, the COX-2 inhibitors work, and then lipoxygenase pathways to get into the leukotrienes. So these are all generally pro-inflammatory type things. And, if you read the handout, you sort of see where we're going with some of this. But, all right, so let's look at what we got here. So when we're talking about fatty acids, going to do just a little bit of talking about them, because we get asked the question. I get asked the question a lot about fatty acids, so I was sort of interested, what's going on with all this business. And so arachidonic acid is an omega-6 fatty acid, and it can get shunted into some of these more inflammatory prostaglandins and leukotrienes. Eicosapentaenoic acid is EPA. Docosahexaenoic acid is DHA. Generally, in fish oil, it's a combination of these two. And EPA is studied a little bit better and probably has a little bit better data than DHA. The two of them in combination, it may be ratios. We're sort of not clear on it. The American Heart Association or Cardiology Association or whatever recommended that people eat fish 2 times a week. And so the vegetarians throw up their hands and they're like, well, what do we do? And so we don't really know. They can take a fish pill if they're willing to do that. Or the other possibility, the only plant source of omega-3 is alpha-linolenic acid, and it's hard to get that and it's not studied, but if it were a vegetarian, I'd recommend that. So alpha-linolenic acid, they can buy that at sort of a Trader Joe's type store. And you can see that these also get shunted into prostaglandins and leukotrienes, but they're less inflammatory. So the issue is that we eat, so most of these are in our diet. And in a modern American diet, or really a modern Western diet of any sort, generally the amount of omega-6s that we eat is just way too high in proportion to the amount of omega-3s that we eat. And that generally just likely leads to a more inflammatory milieu for our body. So all that McDonald's that we know and love is tons of this and none of that in there. So let's look at what's sort of going on with these things and what they might look like so we can sort of get a sense of it. So the first number is the number of carbons. So I guess we can start with, do you want me to draw any of them in particular? Like a fun one? You want to see what EPA looks like? Or all of them. All right, we're going to draw them all. Speed drawing. So we'll just draw, I guess, icosapentaenoic acid. So that's EPA. It's 20 carbons. So that's the first number. The second number is the number of double bonds that it has. And so when we're talking about double bonds in a fatty acid, if it has no double bonds, it's a saturated fatty acid. If it has one double bond, it's a monounsaturated, and if it has many, it's a polyunsaturated fatty acid. So these are all polyunsaturated fatty acids. And then the omega-3 is which carbon is the first double bond. And so once I draw one of these, you'll understand how to draw all of them. So all that we do is we start on one end, and we draw our little carbon stuff. So it's one of these will work. The third bond is the first with a double bond, so that's 1, 2, 3, and then we draw our double bond, and it has how many? 5. 2, 3, 4, 5, and I get to look really smart, and I haven't really done anything here. And then all we have to do is count to make out to 20. So 1, 2, 3, 4, 5, 1, 2, 3. So that's the omega side of 3. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. And then it's a carboxylic acid, so we have the double bonded OOH. And so this is what EPA looks like. And so this would be the alpha one molecule, because you generally, because it's the important one in the IUPAC system. But as opposed to calling it an alpha, because that's an alpha 18, that would be the equivalent. We just name it from this side because it's easier. So if you see something like this, it's generally on the omega-3 side and better. It would go out further and then be at the omega-6, and that would be sort of your more inflammatory one. And so now you sort of, when people talk about omega-6s and fatty acids and omega-3s, you can sort of understand what they're talking about and what it looks like and why it's important, because we're talking about inflammatory stuff. All right. Now onto the lectures that are the slides that actually matter. So now I'm going to try and relate this to clinical stuff and to just sort of common sense stuff. So I talked a little bit about the common cold in the handout. So when you get the common cold, when you get a virus, when you get a bacterial infection, it's generally not the virus or the bacteria that makes you sick, that causes physical symptoms. It's generally your body. And that's not always the case. Some things make bad things. But generally, it's just your body fighting it. And so, I would think about what it feels like to be sick. And, again, I can lead the witness, so to speak. Your sleep gets messed up. You sort of lose interests in stuff. You're not really too excited to do stuff. Your energy is down. You're not thinking really great. Your appetite's not so great. You've got sort of an upset stomach. You're irritable, and that really looks similar in a lot of ways to depression. And again, just looking at a little bit of associative type stuff. Not in any sort of way saying that depression and the common cold are the same thing, just seeing at how it's possible that there's an underlying neurobiology that's similar between the two. So we'll talk about our drugs. And pretty much we found that any of our drugs that work, and that's certainly true with the SSRIs, SNRIs, and with the dopamine antagonists. I'm not sure about some of the other drugs, but when we give them in depression, if we check inflammatory markers before and afterwards, inflammatory markers are significantly down concurrently with improvement of illness. So we see some correlation there. If we look at our diseases as compared to healthy controls, medically matched controls, there are generally increased inflammatory markers in depression, in bipolar, in PTSD, in schizophrenia. Different studies show different ones. Different illnesses show different ones. Mania actually has some of the best data for being an inflammatory condition. And again, it's not proving anything. The data's all over the board, but it's sort of saying, hey, there's probably a signal here. And then the next one is I'm going to give a whole slide to the idea of other diseases being mediated by inflammatory things. But, obesity has an inflammatory component. Cardiovascular disease does. Diabetes does. Lots of bad things. Autoimmune disease does. Migraine does. I don't even know what other sorts of things I wrote. Oh, IBS, fibromyalgia. And then, we start thinking about what is this concurrence, or co-occurring, as psychiatrists like to say. What's up with all this co-occurring business, concurrent business? We have to think back to the idea of Occam's razor and what's really going on. And I'll talk about a little bit, maybe what I think is a mechanism to explain some of this concurrence and what might be going on. And the next one is, I mentioned, the whole point of this is to be able to think in a rational therapeutic way. So if inflammation causes these things or is bad, what would be a great treatment for them? Anti-inflammations, right? To just use our nomenclature. So anything that's anti-inflammatory, just give it a run at it. And, I had suggested some of this last year in research. And again, this sounds like insanity to most people when you talk about it. But there's data that's coming out now that's showing use aspirin at 160 milligrams, I believe, after a failed treatment of Prozac, that versus placebo. People respond way better, and they respond quickly, like after a week to it. Infliximab and etanercept has been used, and that's been positive. Tylenol has been used as an augmentation strategy. That's been positive. COX-2 inhibitors have been used. That's been positive. Statins, interestingly, have an anti-inflammatory component. That sort of, if you look at large-scale data, has been positive. And again, the idea is that it's just a possible another avenue for, a therapeutic approach to be getting into some of these things. All right. Oh, and this also brings up the idea of, antidepressants, right? We have this label of antidepressants, and anything that's an antidepressant, by the FDA gets a label for suicidality. You've got to warn them. They get the black box label for suicidality. So if all of a sudden we do a study that shows aspirin works, what do we do with that at that point? We've got a study that shows it's an antidepressant. Are we going to have to FDA label it as causing suicidality? So what I'm getting at is that we're labeling things because it's useful to label, but the truth is we're just making this stuff up to some extent. All right, so next is non-drug modalities. And so let's think about the non-drug treatments that we have for psychiatry. So we got our whole list of talk therapies. And then we've got all these other things like VNS and DBS and TMS and all that stuff. I'm not going to go through all of them, but let's just think of VNS. So it's a vagus nerve stimulator. What do we know about the vagus nerve? It's involved in what type of autonomic response? Parasympathetic. And so there's something called an anticholinergic or a cholinergic anti-inflammatory pathway, and it's thought to sort of, start in the parasympathetic pathways, get out to the spleen, acetylcholine gets released, and it binds to sort of alpha-7 nicotinic receptors, and it decreases the inflammatory response. And, VNS works for depression. And, when I would have to guess how does it work, my guess is that's the mechanism through which it works. And I've never seen people use VNS for autoimmune disorders. I searched for it. I didn't find a single study. I bet it works. I would be willing to bet. If you do it, you're going to get some response to it. And then that sort of makes the leap to, what about just deep breathing? What about just meditation? And I don't know what this is a critique of, whether it's just American thinking or guy thinking, but we have this sense of, things that are bigger and flashier and more expensive are better, and everything else just doesn't work. It's not worth our time. And Marlene Freeman uses this phrase like nuts and berries. Doctors can traditionally be like, oh, that's just silly, that's ridiculous. But my question is, why? Why do we have this assumption that just because something isn't expensive or made in a laboratory that it can't work or it can't work as well? And I don't really think there's a lot of sense behind that. So that gets us back to the idea of conditioning, like we had talked about before with Cytoxin and saccharin, and how can we use that? How can we use that to help our patients? And I'll just sort of leave that as something to brainstorm. But the idea is that, if we can help people with an anchor, if they can get to their safe spot, and we can teach them how to get there, that's sort of what we're doing when we're doing therapy, when we're teaching people how to modulate stress. This is what we're getting at. All right. So I've got a couple more slides. I'll try and go through them relatively quickly. The next is change over time, because another point that I make a lot is that we love to look at snapshots. That's all that we do. What's this right now? What's this right now? Let's make a diagnosis. But that's not really what happens. We're organisms that change and evolve over time. Our diseases change and evolve over time. I'll get you all out of here quickly. Just going to draw a couple of things. So these are a couple of diagrams that I'm stealing from Robert Sapolsky, but I think that they illustrate a good point, and I think it matches what we see clinically pretty well. So if we have, let's just say, if this is our immune function, we'll just do this sort of thing. Actually, let me just do this first. All right. That's a normal immune response. We've got 100% immune functioning. A stressor happens. Epinephrine causes this to bump up. The stressor goes away. Cortisol then comes back. The stressor is resolved, and we've got our back to baseline functioning. If we have a chronic stressor, so a stressor that's there that doesn't go away, like we're in a concentration camp, and we're always worried about our lives, I can't imagine much worse than that, you get this sort of thing. So epinephrine goes up, cortisol doesn't go away, and you have a decrease in immune function. You have immunosuppression at this point. That's pretty standard. The next thing that I think is interesting is what happens when you get chronic repeated stressors. So here's our first stressor. We get it, and it goes away. And then we level off. And then we get it, and it goes away. And we get it, and it goes away. But something interesting happens in that our system loses control at some point. And what likely happens is there becomes a point where bad things happen and illness is expressed. And who knows what the bottom one is for you, whether that's going to be an autoimmune disease, whether that's going to be a migraine, or whether that's going to be a depression. But this is the type of thing that we see over time happening. Immune function, immune modulators are going up. Inflammation is going up. And, so I think that that's sort of more of a model that actually mimics what we're seeing and maybe helps to explain some of our illness. All right. Almost done. I think 2 more slides. Oh, yeah. So this is getting at the idea of concurrence and what maybe is going on in these things. So you see these sorts of things over time and kindling models and all that sort of thing. But I'm going to draw something that's going to be super, super sloppy, but hopefully it'll get the idea across. All right. So this here is going to be sort of our stress level here. This is going to be our circadian variation. This here is going to be our substance use. And then we can go, on and on, adding risk factors here. Our hormonal variation of things over time. And these all add up at each point to give us sort of a total risk of things. And then we each have these thresholds, all right? And these are multi-determined based on cognitions, based on genes. And once you sum them up, these are multiply shared risk factors. So the risk factors for depression are both going to try and sum towards depression and cardiovascular disease. And this is much more of a model, I think, of what we're actually seeing in actuality. Of course, it's ridiculously, grossly oversimplified. There's not going to be, a threshold for things based on a gene, but it's, again, getting to our gene-environment interaction, our multiple interactions. It's not going to be simple, but I think that's what we're seeing ultimately.
Sorry, the line next to stress?
Oh, I'm sorry. Yeah, this is just going to be worsening risk, whatever that happens to be. It's nothing in particular. It's not stress. I'm not trying to get at sort of a stress paradigm. The more stress, the worse. This is just a general maladaptiveness, malfunctionness. All right, and this is my last slide. So this is just a little bit of a summary slide. This is a little picture by Kurt Halsey. I love that guy. And so, what's the point of all this? Why are we talking about inflammation? Why are we talking about stress? And it's not so that we think that everything has to do with stress. It's not so that we think everything has to do with inflammation. It's, the point of this is not to lose the forest for the trees, but the reverse of it. To understand that this is really complicated stuff. All these things are going on that we can begin to understand and put into context. But that's not really what we're doing. And what I think we need to do is we need to get more experience near. And I don't know if that term makes any sense. I'm just really making it up. But, when something happens that looks like illness, that's what we need to be studying. So you give somebody interferon and something bad happens. We need to know, I want to know what's that change. What happened that made that manifest? And so, I'll give you an example of me personally. So a few months ago, I was having a really bad time. And, I'd probably even say I was depressed. And I'm not going to say I was major depressed. I'm just going to say that I was colloquially depressed. And I was writing some music, and it was pretty much all done. And I was going to make just sort of a filler riff on the guitar. So I'm sitting, I've got my guitar, I've got my headphones on, I've got my program. I click record. Click, 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 click. Wow, dow, dow. Oh, I messed that up. Stop. All right, record. Go again. Click, click, click. Wow. I messed that up. I sat and played the same riff, 12-second riff. It's not difficult. I'm not bad at guitar. It was a simple riff. I played it over and over and over again. And first, I was just like, this sucks. This song sucks, which then turned to, I suck, which then turned to, what am I doing here? I'm no good at guitar. I've wasted all this time practicing. I look at myself as a musician and I suck at this. Look at all this time that I've invested. This song is terrible. I suck. There's no purpose to this. Life is terrible. So that's what depression is. Okay, that's not serotonin. That's not NFKB. That's not indole 2,3, whatever McGase. So the idea is that there's a human aspect to this. And what was happening there? So I can explain it on a neurobiological level to some extent in each part. So the dorsal anterior cingulate cortex is involved in error detection. Something was going on there that made it more heightened. I made a connection. I was seeing, oh, here's the interesting part. I recently went back when I was sort of thinking about this. Man, it was not good. I was about to start smashing my guitar. I went back into the program and I listened and I counted them. There's 87 takes of this, 12 seconds long. It's complete insanity. They all sound exactly the same. There's no mistakes. I mean, yes, you can be picky and say, oh, that note wasn't perfect. Oh, that note's... It's crazy. But that's what can happen when a module goes wrong. But understand, that's not serotonin. That is simply one thing that is in the context of a human life. And that's what our illness is. And I wrote it down so I don't mess it up. So, our illness is aberrancy in a functionally relevant pathway in the context of a person's humanity and their environment, their personality, what makes them them, their uniqueness, and their environment. Serotonin does not explain these things. That is what makes up the fuel, the metal, the rubber of the mechanical property. But to understand these things, we've got to put it all together and see the bigger picture. And that's what we're heading towards. When these things mess up, what are they messing up that means something to a human being? And that's what I want to know. That's what I want to sort of be able to help people with and help people deal with. And so again, the idea of this is we want to be able to grow to be able to understand that in the context. Of course, the dorsal anterior cingulate does a lot more than just error detection, but it's a neuron. It goes by the rules of ions, which go by the rules of receptors and all that sort of stuff. We need to know it all, but we want to get this holistic picture. We don't want to focus on a snapshot that's really pretty. So I'll leave you with a few things. And it's really hippie, but I think that it's sort of, they're interesting ideas. And so, one thing is, what can we do with all this? We don't need a mechanism of action, right? We don't need anything fancy. How can we help people? We can help people by helping them decrease their stress. We can help them the same way we'd help a friend. We help them with control. We help them with understanding. We help them with predictability. We help them with social support. And then sort of taking a step back, and this is, again, getting a little bit political, but the idea of, what is the problem in the world? Why are things the way that they are? And when you start looking at things epidemiologically, there are certain things that are bad. A decrease in social equality, a big difference between rich and poor, decreased social capital, not viewing each other as friends, viewing, your neighbors, you can't ask them for sugar. And this sounds really, really cheesy, but, this all started off as stress as a pathogen, right? And the idea of if you want to cure a pathogen, if you want to cure a bacteria, you don't treat the individual. You stop it from getting a foothold, you stop it from spreading. And so it's the idea of herd immunity. If I'm nice to you, you're nice to him, he's nice to me, and sort of we decreased everybody's stress. And that's a lot harder to do than it is to say, because we're humans and we're programmed to look for outlets for frustration. And the most efficient outlet for frustration is to take your aggression out on somebody else. Consistently. If you want to feel better, beat somebody else up. It works. But that's not helpful in a larger context. What we need to do is, if everybody helped everybody out a little bit, I think that we could go a long way into really just making the whole world a little bit of a better place. And so that's the message that I'll leave you on. It's a little bit hippie, but I really believe it. I mean, and I think that's what we see. These kids who get treated poorly, then go on to treat people poorly and do unwell. And, when we see somebody who cuts us off on the street and gives us the finger, that makes us upset. If we could just tone that down a little bit, I think that we'd all be a little bit better off, serotonin or not. So I thank you for your time. Do you all have any questions for me?
So we're going to have a group hug now?
Yes, absolutely. I would love to give you a hug, Dr. Hobbs.